Welcome to the Motivational Midwife. My name's Lynn Jones, and today we're going to look at blood groups and anti-D. Okay, so let's have a look at blood groups and anti-D. So how do you get your blood group? Well, it's inherited from genes that your parents pass on to you. And your group is actually determined by the antigens and antibodies that are on the red blood cells and within your blood system. The two most important systems from a blood transfusion perspective that we are interested in and for pregnancy is the ABO system and the RH, which you might know as rhesus factor. However, really, officially it should just be RH because rhesus refers to the monkeys, rhesus monkeys, not the actual blood group. There's four main groups within that system, and we'll talk about those a little bit later as we're going through this presentation. So a quick review of blood. So blood cells are formed in the red bone marrow, and 45% are red blood cells, and they are important in carrying oxygen to all the tissues of the body. Less than 1% are white blood cells and platelets, and so the white blood cells obviously crucial in your immune system, and platelets very important in blood clotting. So that leaves us with 55%, which is plasma, and plasma is a yellowish liquid, and it has within it proteins and salts, and that's important when we start looking further, because antigens are sugars and proteins that actually coat the surface of that red blood cell. And antibodies are present in plasma. They're part of the defense system. So what antibodies do is they recognize foreign antigens, so foreign sugars or proteins that are in the body, and they destroy them. They instruct the body to destroy them. So the presence of A and B antigens and whichever antibodies that correspond to those will determine what blood group you are. So you will have a combination of either no antigens, so no A or B antigens on the red blood cell, or just A antigens, or just B antigens, or you'll have A and B antigens on the red blood cell. So if you are blood group O, which I am, that means that I've got no antigens on my red cell, on the actual surface of my red cells. But in my blood plasma, I will have anti-A and anti-B antibodies. And as you can see from the rest of the group, if you're blood group A, you will have A antigens on the surface of the red cell, and therefore you will have anti-B antibodies in the plasma. And likewise for B, you will have anti-A antibodies, and AB, you will have A and B antigens on the red cell, but no antibodies. Okay, because your body is used to that. That's part of your normal body. You've got both of those antigens. So there's five main RH antigens. So there's big C, little c, D, which is the one we are most familiar with, and big E and little e. And there are lots of other ones, antibodies as well, antigens you'll hear about. But these are the five main ones. So your RHD is the one from immunogenic response perspective that gives the most reaction. So you're more likely to get a reaction, a transfusion reaction. So if you have an RHD antigen, okay, positive blood groups. So that would be like I'm O positive. Okay, so I have that RH antigen in my blood group. So there's 77% approximately of the population will be Rh positive. They've got that antigen. If there is an absence, and 23% of the population have RHD, an absence of that RHD antigen, so they will have a negative blood group. So this would be your, what we would refer to as our rhesus negative women. Childbearing women, they should have no Rh positive blood unless it's an emergency, and we'll go on to why this is important. Okay, so what is anti-D? So anti-D is a medication that we offer to women who are Rh negative to prevent an isoimmunisation occurring, and I'll talk about that a little bit more in a second. It's a concentrated antibody, and it's made from blood plasma that we collect from donors, not we as in midwives, but the blood transfusion service collect it from donors, and it's given by injection. So it's important to remember that this is a blood product, and therefore when you are collecting it, checking it, administering it, it comes under the same rules as many other medications, but specifically blood. Okay, so you need two registered practitioners to be checking it and making sure that it's the correct dose and drug medication to be given to the women. So isoimmunisation, this happens when you've got the protein in a pregnant woman's blood. So that protein we said that's on the surface of that red blood cell is incompatible with her babies. So essentially, if you've got a Rh negative mother, but the baby is Rh positive, then what will happen is that her immune system will react. Those antibodies will see that as a problem, they'll react, and they will send out a message to destroy those foreign cells, the baby's cells. Okay, it's sometimes referred to as Rh sensitization or incompatibility, or sometimes you will hear it referred to as hemolytic disease of the newborn, or HDN. So why do we worry about it? Well, if, as I say, if the baby is rhesus positive, there's possible hemolysis. So this is where the red cells will break down, and this can be extremely dangerous for the baby. It can cause fetal anemia, it can cause hemolytic disease of the newborn, it can cause all sorts of problems for that baby. Okay, it rarely affects the first baby, and that's because there's no spontaneous anti-D antibodies within the maternal circulation. These are created once she's had that sensitizing event, okay, and that will happen when fetal red blood cells cross that placental barrier. So the most likely time for this to happen is delivery of the third stage, because up until that point, fetal and maternal circulation are very separate. But as the placenta separates, you will get damage to the blood vessels, and so there is the potential for some fetal blood to enter the maternal circulation. Okay, if you have a rhesus positive baby, then those antibodies will be produced at that point, so they will already be in the maternal system. So when the woman falls pregnant for the next time, if that fetus is rhesus positive, the body will instantly see this as an issue and set up that response to attack those fetal cells. So we've said about isoimmunisation, but we've also got ABO incompatibility, which can cause a problem. And sometimes there's a bit of confusion around these because this really hasn't got anything to do with the rhesus factor, the Rh factor. It's actually about the blood group. Okay, so you've got isoimmunisation when the maternal blood protein is incompatible with the fetus. So you've got Rh negative mother, Rh positive fetus, and the maternal immune system reacts, and it will destroy those fetal blood cells, which will cause hemolytic disease of the newborn. With ABO incompatibility, this is where the maternal blood group, and it's most commonly mothers with O positive blood group or an O blood group, and the baby is AB or AB. And therefore the blood group can cause issues as well, so the body can still see that as a problem. The symptoms are often much less severe with ABO incompatibility than it is with the isoimmunisation. So what sort of risk factors have we got then? So anything that is likely to cause, we've already said, most of the time the maternal fetal circulation are separate circulations, okay, and the placenta is kind of buffering each. But if you've got anything that interferes with that, so anything where that placenta may be disrupted in any way, so either a spontaneous miscarriage, therapeutic, so terminations of pregnancies, if the baby has unfortunately died in utero, so an intrauterine death, if you have got a miscarriage where the woman has then had to go to theatre for evacuation of retained products of conception, ectopic pregnancies, all of these potentially can cause that sensitizing event where fetal cells can go into the maternal circulation. Any vaginal bleeding, because we don't know where that's coming from. Amniocentesis, again, because it's an invasive procedure, there is that risk of feto maternal bleed. Any antepartum hemorrhages, again, the same reason, you potentially have got that route in for fetal cells to get into the maternal circulation. Your external cephalic version, again, because it can cause a problem. So you'll find women who are rhesus negative having ECV will automatically be often prescribed a prophylactic dose of anti-D. And any trauma, and often this is the blow to the abdomen is often a toddler. Previous child that's a toddler has jumped on the mother, or she's carrying them and they've kicked out. It's not specifically falls and road traffic accidents that are the most common thing that you see. It's more often women coming in that the toddler has kind of jumped on them. So antenatal management of this. So at a booking appointment, the midwife should explain all of the blood tests to the woman, and also explain to her that if her blood group is Rh negative, that she will be offered anti-D. Okay, the booking bloods will then be taken, usually around 8 to 10 weeks, and within those booking bloods, blood will be taken to determine her blood group and Rh factor, whether she's positive or negative. And the results will go back to your community midwife, and the woman will receive them from her community midwife. Should she be Rh negative, then depending what the system is within your own hospital, the doctors will prescribe a prophylactic dose of anti-D. Usually it's about 1,500 international units, and that will be offered to the woman at between 28 and 30 weeks of gestation. And before they give it, they will also take some blood. Okay, so they will check again to see if there has been any issues prior to her having that anti-D prophylaxis. If there's any sensitizing events after 20 weeks, then Kleihauer bloods, so you're taking bloods to check for any feto-maternal hemorrhage. So Kleihauer is what those bloods are called, and you're obviously probably quite used to hearing that from when rhesus negative women have delivered and you've taken those cord bloods and maternal bloods for Kleihauer. So before 20 weeks, Kleihauer is not necessarily required, because the amount of fetal blood volume before 20 weeks is insufficient to, even if lots of it got into the maternal system, it would not exceed the amount that the minimum dose of anti-D would cover. So often you find if you've got a woman that's come in with some bleeding or abdominal pain that's pre-20 weeks, they will just prescribe 500 international units of anti-D and not take the blood specifically. If you have a known rhesus negative fetus, then it's irrelevant because the woman won't need anti-D and she won't need Kleihauer's taking, because we know that baby is rhesus negative, and that will have been determined if she's had some screening, some invasive screening during pregnancy. And if any sensitizing event happens before she's had anti-D administration, we're going to need to take if she has a sensitizing event, you need to take a Kleihauer before you give the anti-D, because depending on how big that feto-maternal bleed is, will determine how much anti-D she will require. And post-delivery, which is the one you are most familiar with, you will take Kleihauer, but also a direct antiglobulin test, which used to be called direct Coombs test. You may have heard it as that. And they will be taken. So in my trust, it's a big red bottle and a little red bottle from the mother and the baby. So if we know we have a rhesus negative woman and the baby is deemed to be rhesus positive, we know that that woman is going to require at least 500 international units of anti-D within 72 hours of birth. This is the window you have to prevent a sensitizing event. And I always explain, this is a very simplistic explanation of anti-D to women, but I kind of explain it that anti-D is like a little overcoat, so it goes around the body looking for those rhesus positive cells and puts a little overcoat on it so that the body can't recognize it as a problem. Which is very, very simplistic, and it is a little bit more complicated than that. But it is a very simple way of helping women understand what anti-D does and how it protects both this baby they're carrying and future babies. Okay, so what the Kleihauer and the Coombs test establish is the blood group of the baby, but also the volume of fetal cells that are in the maternal blood, as well as any maternal antibodies that are in the fetal blood. And again, this will determine whether there is the dose of anti-D will be sufficient. Okay, you need to document your results when they come back from the lab, and whether she's had anti-D or not. And as I say, you need to remember that it's a blood product, so you need to follow all the correct procedures for administration of a blood product. So what sort of signs and symptoms might you see if you have got either ABO incompatibility or a positive baby and a negative mother? The things is, a lot of it is about education and making sure that the mother is aware that she needs to be really on the lookout for jaundice, early jaundice, because jaundice is a product of that hemolysis of those red blood cells. And often with a severe reaction, you will get jaundice very early and often much less than 24 hours. So with the ABO incompatibility, sometimes it doesn't really sort of show itself till 36, 48 hours. And then that can be quite difficult to differentiate that between that and a physiological jaundice as well. They're often poor feeders, they're often quite lethargic. You'll need to take serum bilirubin estimation, and this is done via a heel prick, getting the sample of blood and sending it to a lab for proper serum bilirubin estimation. In a lot of hospitals as well, they have a little handheld monitor called TBR, so total bilirubin monitor, and it can be put on the skin to get a reading from that, but a lab sample is the most accurate. We need to encourage regular feeding because the fat in the milk will help that baby excrete the bilirubin that's building up from the hemolysis. And babies very often will require phototherapy. So when the serum bilirubin result comes back from the lab, it will be plotted on a specific chart that takes into account the baby's exact age, and if it has a line on the chart which will tell you if it crosses that line, the baby will require treatment, so either phototherapy, or if it's way above the line, an exchange transfusion. So it's very often plotted as if it doesn't require treatment, your documentation will often say that the result is 6 lines below treatment or 4 lines below treatment. It check in your trust as to how it is done, but that's a fairly standard way of documenting bilirubin results, but it does really need to be the lab results that are documented. Exchange transfusions are really when the levels are very, very high, and we worry about very high levels because they can lead to a disorder called kernicterus, which will lead to brain damage. So this is why we get very worried about jaundice, and jaundice will appear because of hemolysis, that breakdown in red blood cells. So it's not just the ABO incompatibility or the rhesus incompatibility that will be the problem, but infection can cause this as well. Prematurity can cause early jaundice. There are a number of things that can cause early jaundice, but the signs and symptoms will be very similar, and the treatment will be very similar, and the things we are looking out for and worried about will also be very similar. And there you have it, anti-D and blood groups. I hope you found that useful. If you haven't subscribed to the channel already, please do so, and I look forward to seeing you next time.